Diarrhea is based on stool weight, and this is largely dependent upon the environment and the diet. So in the developed world, again, the normal passage of in an adult would be 200 grams a day. In the developing world, again, because of the environment, because of water access and the cleanliness of water, and because of the diet, in general, stool weight is greater and would be 400 grams, up to 400 grams per day would be normal, or more than 3 bowel movements a day. So this is sort of a basic primer on how you define diarrhea, but obviously there are variations. So then we have to determine whether the patient is incontinent, do they have urgency, tenesmus. This is highly personal, and what you're really looking for in any history is whether there's a change in bowel habits. That would be the most relevant information in any individual patient. We process a whole lot of liquid every day. And as you can see here, the diet is a relatively small component of the amount of secretion that the GI tract has to handle, comprising 1.5 liters. We also have 1.5 liters of saliva, 2.5 liters of gastric secretion, pancreatic, biliary, intestinal, and yet we only put out up to 200 milliliters a day. So we have a very, very effective water absorptive mechanism throughout the GI tract. Most of this fluid is absorbed in the small bowel. However, the colon is the most efficient absorber. So the greatest percentage of fluid entering the colon on a percent basis would be absorbed in the colon as opposed to in the small bowel. So the most is absorbed in the small bowel, but the most efficient absorptive mechanism is the colon. The intestine is both a secretory and an absorptive organ, as you all know. Different cell types, as we'll see in a subsequent slide, are responsible for both secretion, for either secretion or absorption. Diarrhea is not only related to the fluid content of the stool, but also related to intestinal motility, which brings in a whole other array of determining factors involving the enteroendocrine system and the neuroenteric system. As shown in the previous slide, 9 liters of fluid in an adult enter the small intestine daily. 7.5 are absorbed in the small intestine, about 1.5 in the colon, but again, the colon is the most efficient absorber, and we end up expelling up to 200 milliliters. This is a classic article by Henry Binder in the New England Journal of Medicine. It's still very relevant. And what we see here are the various cell types that are involved in either absorption or secretion. So to the upper right, we see the typical intestinal epithelial cell with the microvillus membrane at the apex. And here we have chloride bicarbonate exchange, sodium hydrogen exchange, all of which is regulated via cyclic AMP and sodium potassium ATPase, which maintains the appropriate electrolyte gradients. Potassium inside greater concentration, sodium outside greater concentration. And this is what we call the active transport mechanism of the intestinal epithelial cell, sodium potassium ATPase, energy requiring, ATP requiring, located on the basolateral surface. The basolateral membrane, thus, is shown in the middle, is a net secretory cell, whereas the microvillus membrane is a net absorptive cell. This is all then controlled through a variety of mechanisms involving the enteroendocrine cells, shown at the lower left, and enteric neurons, shown on the lower right. All of these work together in order to regulate the processes of absorption and secretion in appropriate levels to maintain electrolyte and fluid homeostasis. We previously discussed, when we were talking about intractable diarrhea, the problem of enteroendocrine cell dysgenesis. Here again is a slide showing a chromograninase stain. On the left, You see the enteroendocrine cells being stained. On the right, they're not stained, dysgenesis. So what are these enteroendocrine cells? They're spread as single cells throughout the GI tract, and they secrete what are known as incretins. Incretins include gastric inhibitory peptide, glucagon-like peptide 1, and other hormones secreted include somatostatin, motilin, cholecystokinin, neurotensin, VIP, and enteroglucagon. So you can see they control not only motility, not only absorption and secretion, but also are involved in glucose homeostasis. So these are extremely important cells that are sort of the regulatory cells of absorption and secretion in the small intestine. These incretins, as I mentioned, GLP-1 and GIP, will stimulate insulin release, inhibit glucagon release, and result in lowering of blood glucose. So one of the problems with enteroendocrine cell dysgenesis is dysregulation of glucose homeostasis. So, no surprise, we go through the processes of absorption and secretion. And what are the processes that result in diarrhea? Well, you can have malabsorption, which is an inhibition of absorption. We can have active secretion. We can have an excess of osmotic agents drawing water into the bowel and accelerating bowel motility, and specifically altered intestinal motility per se. In many, if not most cases, however, patients with chronic diarrhea may have a multifactorial problem. And it is our job to try to analyze the pathophysiology and determine which processes are going awry. So let's talk about the ways to classify diarrhea. First, pathophysiology. Is it osmotic or is it secretory? Well, what's the best way of doing that? We've talked about this before. We know we can measure stool osmolality, we can measure stool sodium, and we've discussed what the so-called osmotic gap is. In patients who have an osmotic gap, that would mean higher osmolality in the stool as opposed to in the serum. That suggests or indicates that what we have is unabsorbed milliosmoles that are drawing water into the bowel. Those diarrheal states, which are isosmolar, tend to be secretory. Then once we've defined the pathophysiology, we have to determine, is it in the lumen or is it specifically an enterocytic problem? This is where we get into maldigestion versus malabsorption. Is the problem the lack of an enzyme so that you can't absorb any given solute, or is there a problem with surface area or accelerated motility where the enzymatic component may be normal, but the absorptive capacity is reduced? What's the site of the defect? Is it in the small bowel or is it in the colon? What symptoms are present? Is this watery? Is it watery diarrhea, which certainly suggests active secretion? Is it malabsorptive, which would be related to dietary intake? Or would it be inflammatory? Inflammatory, of course, would often be associated with the passage of elements of the blood. And then, of course, duration. I said beauty is in the eye of the beholder. How do we define acute versus chronic? In general, less than 2 weeks would be defined as acute, chronic greater than 4 weeks, and then we have the vast gray area between 2 and 4 weeks, or we have to come up with some decision as to whether a workup and management plan is immediately necessary. Again, osmotic diarrhea is caused by the presence of poorly absorbed luminal osmoles. First, certainly from a carbohydrate perspective, lactase deficiency, late primary or secondary lactase deficiency would be the most common. When sorbitol, which is a glucose alcohol, was favored in sugarless gums, sorbitol was another one. And can anybody think of in toddlers what would be the most common cause of osmotic diarrhea in terms of carbohydrate? Well, it would be fructose, the so-called apple juice diarrhea, because we do have a limited capacity for fructose absorption, and so excess intake of fructose is commonly associated in very young children with an osmotic diarrhea. And then we can use various laxatives, sodium sulfate, magnesium citrate. These are all cathartic agents which induce fecal passage through excess milliosmoles and the passage of water into the bowel and secondary diarrhea. In all of these cases, an osmolar gap will be present where the milliosmoles will be greater in the stool than they are in the serum. Stool osmolality can be estimated by the formula of 2 times the product of sodium plus potassium. The difference between this estimate and the measured osmolality of the stool is called the stool osmotic gap. Usually, stool is isotonic, and the gap is less than 50 milliosmoles. When the osmotic gap is greater than 50 milliosmoles, that indicates an unabsorbed solute, either a medication or an unabsorbed solute from the diet. What are the secretagogues? So what can affect this state to cause increased secretion? Well, the most common would be bacterial enterotoxins, with cholera toxin, of course, being the model. Then we have hormones, serotonin, gastrin, VIP, calcitonin. Inflammatory mediators may cause secretion, such as the histamines and various prostaglandin classes. And then, of course, we know that bile acids are potent secretagogues in the colon. Secretagogues bind to the enterocyte, and when they do so, they activate cyclic AMP, cyclic GMP, and calcium. This leads to an opening of apical chloride channels, the induction of a phosphorylation cascade to activate cyclic GMP and further exacerbate the secretory state, resulting in an active secretion of chloride. And if you have an active secretion of chloride, sodium and water will follow. Bacterial endotoxins causing secretiorrhea stimulate the secretion of fluid, leading to a net secretory state. In general, bacterial endotoxic diarrhea is not associated with morphologic damage, and there's no impairment of sodium-dependent solute absorption. Pedialyte, rehydrolyte, all of these rehydration solutions were developed to deal primarily with cholerogenic diarrhea, because in these secretory states, sodium-dependent glucose transport is not affected. So in these patients, the way you can encourage the absorption of sodium is by giving a glucose electrolyte solution. And therein lies the basis for these glucose electrolyte solutions. So the examples of the secretagogues that we commonly see from bacterial origin include cholera toxin and the various E. coli toxins. By the way, this maintenance of sodium glucose co-transport is an extremely important principle that you need to understand and be able to respond to when you get a question about it on the boards. So now that we've laid the groundwork, how do we finally differentiate the cause of diarrhea? Osmotic diarrhea to the left. Osmotic gap greater than 50 milliosmoles. It ceases on fasting. And generally, the stool sodium is less than 40 milliequivalents per liter. So the first thing you're going to do if you're going to end up admitting a child because of diarrhea is you're going to make them NPO. That's the first step, because if the diarrhea stops when the patient is NPO, you can be quite certain you're dealing with an osmotic diarrhea. In the secretory state, the osmotic gap is less than 50 milliosmoles per liter. It continues on fasting with a very high stool sodium, generally greater than 80 milliequivalents per liter. Osmotic diarrheas are commonly associated with carbohydrate intolerance or excess carbohydrate intake, particularly in infants and young children, where the intake of that amount of carbohydrate exceeds the ability of the small bowel to process it. In the secretory diarrhea, we're dealing with the enterotoxins, such as I mentioned on the previous slide. We also have to worry about iatrogenic causes of diarrhea in the osmotic state. That would be magnesium-containing antacids. And keep in mind, Miralax is an osmotic agent, so it'll cause diarrhea. In terms of hormonal causes of secretory diarrhea, we're dealing with vasoactive intestinal polypeptide, gastrinomas, carcinoid tumors, and patients with endocrinopathies. And finally, in osmotic diarrhea, sorbitol, as we mentioned, which was commonly, may still be contained in sugarless gums. And then any patient with ileal dysfunction, very important when we discuss our patients with inflammatory bowel disease, any patient with ileal resection or ileal dysfunction may malabsorb bile salts, and bile salts, bile acids in the colon are very potent secretagogues. And then, of course, we can have the disorders of ion transport per se, which we discussed previously when considering the problem of intractable diarrhea of infancy.
For the benefit of the residents, 24 hours NPO.
24 hours NPO. That's what you're going to do, obviously. So, malabsorption, all right? Malabsorption, as I mentioned earlier, this is the tell them what I'm going to tell you, and then tell you what I told you. Impaired digestion involves impaired enzymatic hydrolysis in the lumen. Impaired absorption is impaired transport at apical membrane, problems with intracellular metabolism, repackaging, and secretion. It can be as simple as a problem with villus architecture with reduced surface area, or it can have a more complicated process involving intracellular elements as well.
Quick question from a clinical standpoint. For all patients who present with diarrhea, new patients, should we be then making them NPO even if they're not vomiting?
No. The only patient you're going to make NPO is the patient you're going to admit to the hospital. You're not going to send any patient you admit for chronic diarrhea, unless you know what the problem is. If you know in advance what the problem is, you manage them specifically. But if you get a call from the ED, I've got this patient who's had watery diarrhea and is dehydrated, you're going to admit him and you're going to make him NPO for 24 hours.
Got it. That makes sense. Thank you.
Yeah. So, what are the causes of maldigestion? Well, they're numerous. Inborn errors of intestinal enzymes, the most common being.
Can you repeat that, please? Sorry.
What's the most common inborn error of intestinal enzymes?
Cystic fibrosis?
That's not an inborn error of intestinal enzymes. What is cystic fibrosis a problem of?
The CFTR transmembrane regulator?
That's not an intestinal enzyme. I'm talking about intestinal enzymes. What enzymes are malfunctioning in cystic fibrosis?
Pancreatic.
Present.
Pancreatic.
Pancreatic, all right? We're not talking about the pancreas. We're talking about inborn errors of intestinal enzymes, the most common being congenital sucrase isomaltase deficiency. All right? Again, popular board question. Inborn errors of bile acid synthesis and transport. Okay, so we will be talking about those, and I think we talked about them last year. We'll do it again. Patients with severe chronic cholestatic liver disease, cystic fibrosis, inherited and acquired chronic pancreatitis, dumping syndrome. This would be common in someone who's had bowel surgery, patients with short bowel syndrome, and that's clearly the model for reduced surface area. All right. What's another model for reduced surface area? What's the most common model for reduced small bowel surface area? Present in a significant percentage of the population. All right, this is the kind of thing that you should answer in a millisecond. Celiac disease. Celiac disease may involve both problems with intestinal enzymes, but importantly, if you have villus atrophy, you have a reduced absorptive surface area. That is going to lead to both maldigestion and malabsorption. And then, of course, iatrogenic, the use of hyperosmolar formulas, which Dr. Rabinowitz and I used to see all the time when the initial protein hydrolysates, progestamine, nutramigen came out. They were all very hyperosmolar, and they caused significant problems. That is not the case anymore. And then, of course, excess dietary osmoles, sorbitol and fructose being two examples here. Causes of malabsorption, diffuse small bowel injury. Here we have celiac disease again, which can be involved in maldigestion and malabsorption. All right. Congenital transport defects, glucose galactose transport, sodium hydrogen exchange. That would be congenital sodium diarrhea, congenital chloroduria, the former being a problem with sodium hydrogen exchange, the latter being a problem of chloride bicarbonate exchange. Then we can have the ultrastructural abnormalities. Again, all of those things that we discussed, microvillus inclusion disease, tufting enteropathy, A-beta lipoproteinemia, which will prevent the appropriate packaging of lipid intracellularly, and lymphangiectasia, again, with the problem of lymphatic transport. And so we have malabsorption of lipid in both cases. In patients with watery diarrhea that is secretory, we're generally dealing with very large volumes of watery stool that is passed. It persists on fasting, and it is the result of a promotion of active intestinal secretion. This is in contrast to an osmotic diarrhea, which ceases on discontinuation of ingesting the causative agent, either a food or a drug, and is most commonly carbohydrate induced. Again, this is the model. This is the explanation of why you make these patients NPO if you're going to admit them to the hospital. Okay. Inflammatory diarrhea, we see commonly. These patients are generally symptomatic beyond the diarrheal state, including problems of abdominal pain, fever, and or bloody stools. Generally, they may show leukocytosis, and certainly if you have a patient who acutely develops these symptoms, you want to do stool analysis, not only for blood, but also looking for leukocytes. Simply on a right stain of the diarrheal stool, you can look for leukocytes. That would certainly give you clear evidence of an inflammatory state. So when you have inflammation-induced diarrhea, the mechanisms include stimulated secretion and inhibited absorption. That's number one. Number two, inflammation stimulates the enteric nerves. So we have propulsive contractions and again, a stimulation of secretion. Inflammation leads to mucosal destruction, which increases permeability through paracellular mechanisms, further loss of fluid, and also clearly reduces surface area. And then, of course, when this happens, you're going to have nutrient maldigestion and malabsorption. Patients who have chronic diarrhea, however, may not always have watery diarrhea. They may have fatty diarrhea. And this is particularly true in patients, again, going back to cystic fibrosis, patients with pancreatic dysfunction, and patients with lipid metabolic difficulties such as A-beta lipoproteinemia and lymphangiectasia. Typically, these stools are pale and oily. They may float on the toilet bowl. I love the term malodorous. I'd like to see a stool that's not malodorous, but again, this would be a change. And in general, patients who exhibit excess lipid in the stool, steatorrhea, will have a stool fat greater than 7 grams per day. The most common causes in pediatrics would be, of course, cystic fibrosis. The other important one would be Shwachman-Diamond syndrome that we'll be discussing later in the year. And we can also have a loss of intestinal absorptive capacity, specifically patients with celiac disease, for the reasons we've already discussed, reduced surface area. And then, of course, patients with cholestasis, if they're unable to maintain a critical micellar concentration of bile acids in the intestine, that will lead to fat malabsorption. The essentials of absorption take place in the small intestine. There, carbohydrates, proteins, and lipids are absorbed to the greatest extent in the duodenum and jejunum. Calcium, iron, folate, and all of the fat-soluble vitamins are absorbed proximally. The only nutrient which is absorbed linearly along the entire length of the small intestine is glucose. All the others are primarily absorbed in the proximal bowel. In the terminal ileum, of course, that's reserved for absorption of vitamin B12, zinc, and bile acids. In terms of the capacity of the bowel to compensate, the ileum can assume additional absorptive functions if the jejunum is resected and impaired. What can the jejunum do in terms of absorption of B12, zinc, and bile acids if the ileum is resected? Anybody tell me? Which of these vitamins, nutrients, and molecules can be absorbed in the jejunum if the ileum is resected?
But
It's a trick question.
none of them?
None of them. All right? None of them. None of them. You will get a small amount of bile salt absorption by passive diffusion in the jejunum, but not enough to maintain an enterohepatic circulation. The ileum can compensate for loss of the jejunum. The jejunum cannot compensate for the loss of the ileum. So when you have a patient with ileoresection, they commonly require certainly B12 and zinc supplementation. In terms of bile salts, that would clearly result in an alteration in the diet to include a higher content of medium chain triglycerides, which don't require bile acid for absorption. All carbohydrates are absorbed as monosaccharides. And the dietary carbohydrates are primarily di and polysaccharides, and brush border enzyme hydrolyze the products of amylase digestion of starch and of the disaccharides all to monosaccharides for absorption. Glucose and galactose are absorbed by secondary active transport via the sodium-dependent membrane-spanning transporter, or SGLT1. If this is not familiar to all of you, it should be. This is Physiology 101. Fructose is absorbed by facilitated diffusion via GLUT5. What's the difference between facilitated diffusion and secondary active transport? Well, secondary active transport of glucose and galactose involves sodium-potassium ATPase on the basolateral membrane to maintain the sodium gradient, because both glucose and galactose are absorbed via sodium-dependent carbohydrate uptake. And so you have to maintain the sodium gradient in order to do that, and that's why it's called secondary active transport. Facilitated diffusion is not an energy-requiring process. What facilitated diffusion involves is a specific transport protein, in this case GLUT5, wherein the designated solute is absorbed at a faster rate than would be expected on the basis of osmosis alone or passive diffusion alone. Got all that? If you haven't got all that, you got to read about it, because this is very important, and all of this likely appears on the boards. Unabsorbed disaccharides are metabolized by bacteria to short-chain fatty acids, and short-chain fatty acids are a nutrient in and of themselves that we will be discussing. When a patient has carbohydrate malabsorption, the common candidate carbohydrates include lactose, sucrose, starch, which requires both pancreatic and intestinal enzyme hydrolysis, and then the monosaccharides fructose and the glucose alcohol sorbitol. Common symptoms: abdominal pain, cramping, bloating, gas, urgency, diarrhea. These patients, because these carbohydrates get into the distal small bowel and colon, are hydrolyzed by bacteria to form short-chain fatty acids. So you look at the pH of the stool, it will be acidic. One of the clinical pearls, if you will, in an infant who comes in with watery diarrhea, you look for perianal excoriation, because if it's carbohydrate, it's very acidic, and it clearly impacts the integrity of the perianal skin, and you'll see it. You can also measure the stool for reducing sugars. And you need to get a very careful history, although there may be a poor temporal relationship of carbohydrate consumption to symptoms. But usually, particularly in older patients, you can associate the ingestion of a particular carbohydrate with the presence of symptoms. So as I mentioned earlier, short-chain fatty acids are produced from unabsorbed carbohydrate. We don't absorb all the carbohydrate we ingest. In fact, 5 to 20% of the carbohydrate is not absorbed in the small intestine. These unabsorbed, I like to use unabsorbed rather than malabsorbed. These unabsorbed solutes are fermented by bacteria in the colon. This is incorrect slide, I have to change it. This is not malabsorbed bacteria fermented in the colon. It's malabsorbed solute or unabsorbed solute is fermented by bacteria in the colon. And this bacterial fermentation results in the production of short-chain fatty acids, carbohydrate, hydrogen, methane, and lactate. What does the colon do? Well, the colon is an important organ for carbohydrate salvage. The colon reclaims energy that from these unabsorbed carbohydrates, generating short-chain fatty acids. Short-chain fatty acids remain important nutrients for colonocytes. And when this happens, this stimulates sodium and fluid absorption in the colon, which is another reason why the colon is a very efficient fluid absorber. These short-chain fatty acids include butyrate and propionate. They're essential for colonic metabolism and maintenance. Acetate is used by the liver as a nutrient. When you have a loss of carbohydrate salvage, this will result in diarrhea. It's one of the common causes of diversion colitis in patients who've had subtotal colectomies, pull-through procedures, and will result in a loss of calories and energy, which may be significant. So, going on further, we have to define the primary and secondary causes of carbohydrate malabsorption. The primary causes include an enzyme deficiency, congenital sucrase isomaltase deficiency, glucoamylase deficiency, and congenital glucose-galactose malabsorption. In our patient population, the only two that we see with any frequency would be late primary or secondary lactase deficiency and congenital sucrase isomaltase deficiency. The secondary causes of malabsorption result generally from diffuse villus injury, celiac disease being an important model, but malnutrition per se will lead to villus atrophy. Viral and bacterial infection may result in villus injury as well, as will allergic enteridities. Of course, short bowel syndrome, the use of antibiotics, which affect the microbiome, and bacterial overgrowth, something that we have to worry about, particularly in our patients who've had surgery for necrotizing enterocolitis and for inflammatory bowel disease. Certainly the most common problem of carbohydrate malabsorption is late primary or secondary lactase deficiency. Late primary lactase deficiency is very common in people of color. The most common in this country would be African Americans, the American Indian, patients subjects of Mexican descent, and subjects of Filipino descent, where they have the highest prevalence of lactase deficiency, approaching 95%. Lactase persistence is higher in Northern Europe. If you're interested, this has an anthropological basis. So if you look in anthropologic history, those populations which were involved in cattle herding are generally lactase sufficient. Those that were not are lactase deficient. The most interesting example of that is virtually no one of Indian, I'm talking about Indian extraction, is lactase deficient, because as you know, cattle are sacred in the Hindu religion, and they were actively milked for nutritional purposes. If you cross the border into China, where cattle were not historically herded, you have a very high prevalence of lactase deficiency. So it's an interesting bit of anthropology. You may want to look it up. The genetics of hypolactasia have been defined on chromosome 2. Lactase persistence correlates with 2 single nucleotide polymorphisms upstream from the lactase gene. One is cytosine for thymine, the other is guanine for adenine. And lactase non-persistence and lactose intolerance correlate with the CCGG phenotype. And even in heterozygotes, lactose intolerance is seen. So over to the left, you can see the CCGG. That's the percent of the total population and the percent of those patients that have a positive lactose breath test, 100%. And then you can see still in the heterozygotes, you have a significant number of these patients who will have lactase deficiency. Lipids. This is certainly the most interesting of the nutrients in terms of their absorption. There are various stages of digestion and absorption. Again, you should all remember this from your medical school physiology. This involves lipolysis, micellar solubilization, cellular uptake, and systemic delivery. In the lipolytic stage, lipases incompletely digest triglycerides to free fatty acids, monoglycerides, diglycerides, and glycerol. Glycerol being the backbone of all of these triglycerides. Lipolysis is enhanced by alkaline pH and detergent properties of conjugated bile acids and inhibited by duodenal acidification. So this is clearly why patients who present with Zollinger-Ellison syndrome don't necessarily present with ulcers, although they commonly do, but can present with diarrhea. They present with diarrhea because of the large amount of acid that passes into the small bowel. We get duodenal acidification and malabsorption of lipid. After the lipolytic stage comes the micellarization stage. Mixed micelles are formed in the lumen of from mono and diglycerides and free fatty acids, phospholipids, cholesterol, and fat-soluble vitamins. These micelles are stabilized and coated by bile salts. And they're coated by bile salts so that the whole micelle can be solubilized in an aqueous environment. In order to do this, the micelles are organized with their polar side chains facing out to allow diffusion across the unstirred water layer and reach the enterocyte membrane. Mixed micelles, as mentioned in the previous slide, then diffuse into the epithelial cell. Bile acids remain in the lumen and enter the enterohepatic circulation. And this occurs 4 to 6 times with each meal. Fatty acids are transported into the smooth ER and re-esterified to triglycerides and phospholipid. Chylomicrons, which comprise triglycerides, phospholipids, cholesterol esters, and apoprotein B48, undergo synthesis in the Golgi apparatus, and these chylomicrons are delivered to the intestinal lymphatics via exocytosis. These are all processes we've already discussed, and that should be a review for all of you. So here, in graphic terms, are the 4 phases of fat absorption. We have triglycerides, lipolyzed to free fatty acids, beta monoglyceride. They undergo micellar solubilization with bile salts. They then can cross the unstirred water layer into the enterocyte itself, where these fatty acids and monoglycerides are cleaved from the micelle, re-esterified to triglycerides combined with cholesterol, phospholipid, and apoprotein B48. They form chylomicrons, and they go to the tissue for utilization of fat. If you understand this, then you can understand everything you need to know about lipid metabolism in the small bowel. The effects of fat malabsorption are obvious, the most prominent being the loss of energy leading to malabsorption, malnutrition, and further problems with nutrient handling. Also prominently, the loss of fat-soluble vitamins, and because we have a lot of unabsorbed fat in the lumen, it forms soaps with calcium and magnesium, leading to loss of these electrolytes. This then can result in increased oxalate absorption. Since calcium oxalate cannot be absorbed, but free oxalate can, this results in oxalate excretion, and these patients are at high risk for kidney stones. This is something you have to be particularly concerned about. I'm sure Dr. Levine will talk about this when she discusses inflammatory bowel disease. The enterohepatic circulation, as I mentioned earlier, occurs 4 to 6 times with each meal. Here, the importance is to maintain a bile acid concentration greater than 4 millimolar. We call that the critical micellar concentration. Any concentration of bile acids below that 4 millimolar level may lead to fat malabsorption. All right, we lose only about a half a gram of our 4-gram pool size of bile acids each day, which is excreted in the stool. This is replaced a gram per gram by synthesis from cholesterol. Bile salt reabsorption occurs very similar to absorption of glucose. It's a sodium-dependent transport mechanism occurring in the ileum. A small amount may diffuse in the jejunum, but the vast majority of it is sodium-dependent bile acid uptake. And then it's probably bound to a cellular component where it then is excreted into the portal blood. When bile salts are not reabsorbed, they reach the colon where they're toxic to colonic mucosal cells, resulting in a stimulation of chloride secretion along with sodium and water and impaired sodium reabsorption, and this may result in a secretory diarrhea. Vitamin B12, remember this is the other element that is absorbed in the ileum. It's cleaved from dietary sources by hydrochloric acid from parietal cells. This salivary and gastric R protein is then bound to the free vitamin in the stomach and cleaved from it by pancreatic trypsin. B12 then binds to intrinsic factor in the duodenum, and the B12 intrinsic factor complex attaches to a receptor in the terminal ileum. The B12 intrinsic factor complex split inside the cell, and B12 binds to transcobalamin 2, and it also is circulated via the enterohepatic circulation. One of the things you should all look up, because everybody forgets it, is the Schilling test. Schilling test part 1, part 2, part 3. In patients who have B12 metabolic problems, one has to define the source of the problem. Does it involve bacteria? Does it involve lack of pancreatic enzymes? Does it involve lack of intrinsic factor? What's going on here? Learn about the Schilling test part 1, part 2, part 3. Another cause of diarrhea, of course, is altered intestinal motility. Promotility agents that are given iatrogenically, hormones, patients with hyperthyroidism, carcinoid, patients with ineffective peristalsis, if they have a neuropathy, diabetes, systemic sclerosis, Crohn's patients, anyone who has intrinsic bowel disease may be prone to developing problems with altered intestinal motility. Especially, you should be worried about patients who've had previous intestinal surgery. They may have a non-modal segment of the bowel, which may be causing problems. This can result in bacterial overgrowth. When you get bacterial overgrowth, you get deconjugation of bile acids by bacteria, and that can result in fat malabsorption. And this is just sort of a schematic of what happens with bacterial overgrowth. At the top, we have the normal distribution of intestinal bacterial flora, and you see to the right the legend showing the bacterial concentration, 10 to the 0 up to 10 to the 11th organisms per milliliter. Until you get to the colon, the intestinal bacterial component is only maximum about 10 to the 3rd organisms per ml. So we have absorption that takes place all along the bowel. Remember, I said glucose is absorbed linearly the entire length of the bowel. When you have small intestinal bacterial overgrowth, shown at the bottom, we now have the part of the intestine, the ileum, and perhaps the jejunum, which may have up to 10 to the 11th organisms per ml. When you have this situation, you have bacteria competing with the enterocyte for the nutrients that are ingested. This can result in bacterial fermentation of whatever is there that they can ferment, and a loss of important nutrients, and of course, the development of a diarrheal state. The complications of bacterial overgrowth include direct injury to the microvillus membrane, the development of disaccharidase deficiencies, deconjugation of bile acids, and bile salt malabsorption, which would result in fat and fat-soluble vitamin malabsorptive problems, the generation of more secondary and tertiary bile acids, including not only chenodeoxycholic acid, but lithocolic acid, which may be toxic to the hepatocyte. And then, because bacteria produce folate, what you see typically in patients with bacterial overgrowth is elevated folate levels and decreased B12 levels. If you see that in a patient with a diarrheal state, they have an elevated folate and a decreased B12, think bacterial overgrowth. Conditions associated with this are numerous. They're shown here. I'm not going to go over them, but again, this should be something that you should read about. So, how do we approach the patient with chronic diarrhea? History, physical examination, stool tests, cultures, ovin parasites. Look for blood, leukocytes. Look for fat with the Sudan stain, pH, reducing substances. Patient who has suggestion of poor growth, we may want to do an alpha-1 antitrypsin level. And we want to look at a stool fat. So alpha-1 antitrypsin informs on protein loss, stool fat, of course, on fat loss. The lab tests, now this is only a rough guide. This is not everything you're going to do in every patient. CBC, metabolic profile, serum lipids, iron, folate, B12, zinc, clotting studies. Remember, vitamin K is a fat-soluble vitamin, as well as other fat-soluble vitamin levels. In a patient with watery diarrhea, you're definitely going to want to look at stool electrolytes and stool versus serum osmolality. Breath hydrogen testing, we don't do that much anymore. It may be useful in certain selected patients. Obviously, we want to evaluate them for celiac disease, and depending on whether or not they have an inflammatory diarrhea or not, we may want to do IBD serologies. Of course, in infants and toddlers with evidence of fat malabsorption, a sweat test. We generally don't do D-xylose absorption studies anymore. Remember, D-xylose is a sugar that is not normally in the diet. We neither hydrolyze it nor metabolize it. So it is really a measure of surface area. It's absorbed by osmosis in the proximal small bowel. And since we don't have any circulating, a lot of it will be absorbed and it will be excreted intact in the urine. And of course, then the patient with watery diarrhea, we can get into more involved testing of specific secretagogues. Breath hydrogen testing, I'm going to skip right over this. This just shows what happens with the breath hydrogen level on the y-axis, minutes on the x-axis. This is a patient who is given the normal would be less than 20 parts per million within a 2-hour testing period. When you don't give the enzyme, you see the red line showing an elevation in breath hydrogen. What about the patient with chronic diarrhea?
Sorry, Dr. Schwartz, we have pathology as well.
Okay, all right. So we can, again, take this up briefly next time. I'll just finish this off next time, and then we can go on to the next lecture, okay?
Thank you.
All right.
Thank you.
A number of modalities, and all of this really depends upon what the nature of the symptoms are, the duration of the symptoms, and their severity, and where you think the lesion would be. And of course, to start off with, is this a secretory or is this an osmotic diarrheal state? So I put these studies up there only to show you that there are an array of modalities that can be used. Perhaps the most difficult one to specifically define is pancreatic insufficiency. The best test we have right now, of course, is the fecal elastase. However, in specialized units that are prepared The most direct way of measuring pancreatic function is through a secretin stimulation test. This requires a double balloon endoscope so you can isolate the ampulla of Vater. The patient is given intravenous secretin, which stimulates pancreatic secretion, and you measure enzymes that are flowing out of the ampulla. And if we look at the analysis and interpretation of this study, you see on the bottom what the abnormal reference values are in terms of trypsin, amylase, lipase, chymotrypsin, and protein. So anything below those abnormal reference values would be considered consistent with some problem with pancreatic function. And indeed, in a patient with pancreatic insufficiency, you see the top, the middle row is pre, and then below it is post-secretin. And when secretin has no effect on pancreatic enzyme secretion, that is obviously the gold standard, if you will, for pancreatic insufficiency. So in our neck of the woods, that is not something that we are capable of doing, but there are specialized centers. But then again, the fecal elastase is a pretty good test, except for one caveat. And that caveat is in any patient with diarrhea, the elastase is going to be lowered. So really, when we're talking about pancreatic insufficiency in a patient with diarrhea, we're looking for values of elastase which are very, very low. Something a bit below normal in a patient with diarrhea is probably not going to be a valuable indicator. In our patient population, really pancreatic insufficiency would be most likely associated with chronic pancreatitis. If you go across the river to Colombia, it would really be cystic fibrosis. So it really depends upon the population that you're dealing with. So we have the upper endoscopy with biopsies. We can do enteroscopy. Again, that's a specialized test. And finally, colonoscopy. Certainly, if there's an indication of an inflammatory diarrhea in terms of symptoms, we would do that as well. And of course, the gold standard in terms of small bowel architecture would be the biopsy. And keeping in mind that many of the secretory diarrheas that we've talked about, in the absence of severe malnutrition, the biopsy is going to look like the upper left. It's going to be normal. Really, these biopsies on the top from left to right, on the bottom from left to right, these are really the Marsh classification. So when you talk about partial atrophy, that's really almost impossible to differentiate from normal, but you can see within the epithelial layer a lot of purple. This is likely because of increased intraepithelial lymphocytes. And so the Marsh 1 classification, we'll talk about this when I give the lecture on celiac disease, involves primarily intraepithelial lymphocytosis. And then we go through the stages of partial atrophy and then subtotal and complete atrophy. Obviously, all that flattens is not celiac disease, but in our population, it certainly would most likely be celiac. And here again, if you look to the lower right, you see the disorganized epithelial layer, and again, with a tremendous amount of intraepithelial lymphocytosis. Under normal circumstances, going back to the upper left, the villus to crypt ratio in terms of height is generally 4 to 5 to 1. If you see on the lower right, that villus to crypt ratio is infinity because there is no villus. So this is something that you all should have experience looking at, and you should always look at every small bowel biopsy that you obtain. That's how you get the experience and the ability to read it. That will come later in the year when I give you the show and tell and show you slides and ask you to make a diagnosis on the basis of histopathology. I can't emphasize too much how important it is to know your histopathology. So to summarize then, we have on the left side going down, history, physical exam, laboratory tests, stool analysis, and the categorization of the diarrhea. And going over to the remainder on the top, when we talk about history, what's the onset, the pattern, the duration? Are there any environmental influences? What are the stool characteristics? Is there incontinence? Keep going on and on and on. These are all the things that we've talked about previously in the last lecture. In terms of physical examination, clearly we want to know, are there other organ systems involved? If they're not, is there evidence of nutritional compromise, evidence of hydration status compromise? These are all extremely important. We're going to get our routine laboratory studies, and then clearly stool analysis becomes important. The most important way to analyze the stool, obviously, is the NPO test in a patient who's admitted for diarrhea. Again, if the patient is NPO and the diarrhea stops, you can be fairly assured that this is an osmotic state. And then finally, we categorize the diarrhea: watery, inflammatory, fatty, secretory, or osmotic. And then we deal with the very specialized tests that allow us to make a specific diagnosis. So what are our take-home points in the approach to chronic diarrhea and malabsorption? History, physical exam, routine labs, stool analysis leading to selective tests, and here are a group of them that we've already discussed, and clearly then the treatment will be based on the diagnosis. Now this is a very quick primer of the diarrheal state. Obviously this is something that you need to go